My name is Haley Muto, and on behalf of the Spokane Regional Opioid Task Force, I want to thank you for being with us for Opioids. Let's talk about it, a community-connected event. This evening, you'll hear about community members and professionals impacted by opioid use, community and family support resources, and be provided with a training on Narcan knowledge and administration. I'd like to invite you to ask questions in the YouTube chat, or you can submit questions through the quiz link when it's being shared. I've pre-recorded a short video of my personal experience. We're going to go ahead and share that with you now. I'm honored to have been asked to share my experience as a family member of a loved one who struggled with opioid use disorder, my younger brother, Marshall Arthur Muto. There are so many addiction stories that result in the loss of a loved one. Fortunately for my family, that hasn't been the case. We've been the exception. There were plenty of times Marshall was standing on death's doorstep, and each event or episode felt like a fire drill that launched us into panic mode, urgently seeking resources and solutions in unfamiliar terrain, simply trying to save his life. This was an ongoing cycle for nearly 15 years for my family and I. And the thing is that we found ourselves doing it over and over and over again, relentlessly. Use began at the age of 13 with marijuana and alcohol. And over the years, he progressed to cocaine, pain pills, meth, and heroin. He ran the full gamut. Marshall lied, broke the law, sold drugs, got expelled from multiple schools, served time in jail on a few different charges, wrecked both of my parents' vehicles, attended treatment 3 times, got clean, lived in sober living homes, got fired from well-paying jobs. He stole anything from anyone just to be able to get his next fix. I recall one time that he stole a gun from me that belonged to my father, and he let me take the blame for it for years. He took my son's prescription codeine cough syrup, pawned my life collection of coins and silver bars. I remember one time that he missed a vein in his arm from shooting up, and it resulted in an abscess that later needed to be lanced and drained. He told me it was from a spider bite. He lived in his car, ran with prostitutes, sold himself for drugs, and through all of this was absolutely cruel to the one person who showed him the most unconditional love, our mom. I remember feeling so emotionally exhausted dealing with the ever-changing needs he required that I told my mom, it's time to show him tough love. Her response to me was, Haley, he won't survive it. And she was probably right. So we didn't stop. Well, more so, she never stopped, ever. We carried on this way until he was 27, so just 2 short years ago. At the time, my parents were having our childhood home remodeled, and no one was living there. One morning, the contractor had showed up to find my brother heavily intoxicated and incoherent in the basement. My parents went to pick him up and take him to my mom's house where he could be monitored. Between my mom, stepdad, and father, he was never left alone for fear he'd quit breathing. 3 days later, when the drugs had worn off, he was taken to a detox facility where he continued to use. So when he came out of detox and was scheduled to be going into his sober living home next, he knew he wasn't going to pass the drug test, so he took off the night before check-in after my mom and stepdad had gone to bed. He went missing for 11 days. On June 11th, my sister called me completely frantic. She said she was driving behind Marshall and didn't know what to do, but she didn't want to lose him. So with 2 of her youngest kids in the car, she kept after him. I jumped in my car while staying on the phone with her to try to catch up to where they were. As we navigated his turns over the phone, we finally followed him into a parking lot where I parked alongside the passenger side of his car, and my sister boxed him in from behind. I got out of my car and opened his passenger door and told the individual that was with him to gather his things and go, because he wouldn't be seeing Marshall again. My sister and I begged and pleaded with Marshall to hand over his keys and get in my car. And after quite a few minutes of resistance, he agreed to come to my house where my parents would shortly arrive and we'd pull together the next game plan. My brother's longtime counselor said to my mom, you'll either pay for treatment now or you'll be paying for his funeral. So 3 days later, we had him on a plane to Costa Mesa, California, where he'd go through detox and treatment yet again. On June 20th, 2020, Marshall celebrated his 2 years of sobriety alongside his family in recovery. Marshall has absolutely flourished, and I lean on him more now than he leans on me. I thank my mom often for never giving up on him because not only is he my little brother, he's my very best friend. Recovery can happen, and Marshall's walking proof. I'd like to introduce to you Stephanie Van Marter. Stephanie is the coordinator of the Organized Crime Drug Enforcement Task Force and Senior Litigation Counsel for the United States Attorney's Office. She'll share a bit on the background on opioids in our community, including trends regarding fentanyl and synthetic opioids.
Hello, my name is Stephanie Van Marter. I'm an assistant United States attorney here in Spokane, serving the Eastern District of Washington. On behalf of the U.S. Attorney's Office and the U.S. Attorney, Mr. Hislop, we would like to thank you for the opportunity to be here to talk to you about our perspective on what we are facing in the opioid epidemic and crisis. I've been asked to talk to you a little bit about what we see from a law enforcement perspective. I know from a law enforcement perspective that we see things perhaps differently than others in the community, but I do know that together we can address this crisis. We can talk about prevention and ways to work with the community so that we can raise awareness on what some of the new threats that we are seeing in the opioid epidemic. The biggest threat that I have seen and that my colleagues and I have been working on for the last 3 years has been the rise of illicit fentanyl. Fentanyl is incredibly potent. It is very dangerous, addictive, and it is deadly. We have seen a rise in the influx of illicit fentanyl made to look just like pharmaceutical medication come into this community, be sold as if it were pharmaceutical medication, and cause the death of so many people who did not know that they were taking fentanyl. It has created a whole new level of addicts in our community that are struggling with this new controlled substance. Together, we can spread a message of prevention and awareness, and that is why we are here. Before we get into some of those threats, let's talk a little bit about what opioids are. Most of us know what opioids are. They are a class of drugs that include illegal narcotics like heroin or synthetic opioids used originally as pain relievers. We know over the last decade that has been abused in various forms, various locations, whether it's abuse of pharmaceutical medications or whether it's abuse of illicit narcotics being sold by organizations. Prescription opioids obviously are a lawful means with which to get prescribed medication to help with pain relief. Synthetic opioids are opioids chemically produced in a lab that mimic the effects of natural opioids. Fentanyl, there is a lawful purpose and prescription purpose for fentanyl. It typically comes in what's called a fentanyl patch, and it's prescribed lawfully in very minute quantity to individuals who are in late-stage cancer or other types of illnesses where it would require that type of strong opioid. What we are seeing and what I'm going to talk a lot about with you today is illicit fentanyl, and that is illicitly manufactured fentanyl outside of a lab with no safety precautions that is placed into pharmaceutical medication and sold illegally to a user. We also still face a significant threat and rise in the use of heroin, as well as other types of opioids that are being mixed with fentanyl or other analogs of fentanyl, like kratom. So our definition of what the opioid crisis is has changed a lot over the years, and we are facing some new, very deadly threats. So what are we seeing here in this community? There's just a few images from press releases or stories about fentanyl here in the community. And we only put those up to show you that it is here, and we have seen it rise since 2016. So how is it affecting us? In 2016, that was the first time that we saw fentanyl in this community. And actually, there was a drug transaction from an organization that was supposed to be 10 kilos of heroin. It ended up being 10 kilos of fentanyl. On the upper picture, there's a stamp of a dancing devil. When law enforcement opened the kilo packages, they had no idea that it was fentanyl. And stamped in the powder was an image of a dancing devil. It smelled different, it looked different. Nobody present had any safety precautions on, and it wasn't until it got to the lab that we were advised it was actually fentanyl. Law enforcement then did not know those threats. Our first responders, our community, we did not know what that meant. Fentanyl itself is transdermal and very, very potent. I'm going to talk about the levels of potency here in a minute. But since 2016, when we had to learn quickly what this substance fentanyl was, we started to see an increase or influx of pharmaceutical pills coming with our organization shipments, co-located with methamphetamine, cocaine, and heroin. And when we started to test these pills, we learned that these pills were not actually those pharmaceutical drugs. Rather, they were fentanyl-laced pills made to look just like a pharmaceutical oxycontin, hydrocodone. In the pictures that are before you, these are just examples of seizures here in this district of thousands upon thousands of fentanyl-laced pills. Just recently in May of 2020, law enforcement DEA in the Tri-Cities seized over 50,000 fentanyl-laced pills in one shipment. So what are the risks with these particular pills? Just to give a perspective, if you have a packet of sugar and you empty out the packet of sugar on a table and you take 5 to 7 granules of that sugar, that is enough to kill somebody with fentanyl, to cause a fatal overdose. There are new beasts being grown out of fentanyl, and one of them is called carfentanil. If you took 1 to 2 granules of that same sugar packet, that would be sufficient to cause an overdose death with carfentanil. There's a visual representation of the 1 gram, a penny, and 1 milligram. Less than a milligram causes an overdose death with fentanyl. It is an incredibly potent and dangerous narcotic that was never ever intended to be made illicitly or to be sold in pill form that it is now. To try and get an idea of what threat we were really facing, I contacted the DEA lab and asked for some numbers. And these numbers from the lab come from actual seizures, so thankfully these substances never hit the streets of our community. But what they reported to me is that between 2018 and the first part or 6 months of 2019, the fentanyl submissions across the country more than doubled. Here in this district, we have submitted a large percentage of fentanyl cases for testing, reflective of what we're seeing on the streets. I think another important thing to understand is a majority of what we're seeing with fentanyl is coming in this pill form, which means it's being hidden in pharmaceutical pills or what are made to look like a pharmaceutical pill. Most of the percentage of them are in pill form, and most of the opioid submittals that the DEA lab is seeing now is fentanyl over heroin. So what that tells us is this opioid epidemic is no longer just contained in a pharmaceutical pill or heroin. It is looking much different, and in my opinion, a lot scarier. If you also look at the breakdown on the screen in terms of fatal doses that have been present in the pills that have been seized and sent to the DEA lab, of those seizures, 13% contained lethal doses. That is 13% of 180 kilograms. And that was just in the first half of 2019. My understanding from the DEA lab is the numbers have continued to increase in fentanyl submissions from this district and from across the country. On your screen are 2 pictures. The top picture is a pharmaceutical oxycontin prescribed, obviously made with pharmaceutical controls. On the bottom is an illicitly made fentanyl-laced pill. Does not have any oxycontin properties in it whatsoever. It is fentanyl and acetaminophen, and it looks exactly like a regular pharmaceutical pill. We can't predict with any kind of certainty or safety how much quantity of fentanyl or even carfentanil is being dumped into the pill presses that are producing these pills. They are being made in super labs, mostly in Mexico. They are pumping out thousands upon thousands of these pills. Now that they know we've seized several of the little blues, is what they call them on the streets, or Mexies, babies, now that we have seized them, they have changed their operations. And now they are making illicit fentanyl pills in all kinds of different colors and shapes and sizes. Dark blue, green, white, made to look like a variety of safe pharmaceutically prescribed medications. Using fentanyl in these types of circumstances is literally like playing Russian roulette, because you don't know how much fentanyl is in any one pill. You could take one day and two the next, and one the third day, and that would cause your fatal overdose. I have had cases where I've had friends who had an addiction, and they went in and bought 7 pills together. In one case, one of the individuals shared 5 pills with his friend, and he kept the remaining 2. He took 2, his friend took 1 of the 5, and his friend died. There's just no way for us to have any idea of what is in each and every pill that is out there on the street, other than to tell you that it can be fatal the first time and in small quantities. Illicit fentanyl today coming into our district is coming through the southern, through Mexico, through the organizations who are focusing on distribution of these pills. It is cheaper for them. It is less risk because they can smuggle pills easier than they can a kilo of cocaine or heroin or methamphetamine. And they are making a lot more money by creating more addicts. Those who are now seeking out Mexis or Blues or fentanyl now that it has been introduced into the market. It's coming in an oxyform, Xanax, Percocet. It's being mixed into marijuana, heroin, and all kinds of forms. So it is out there based upon their need to create a demand. We are trying to track and review the best we can information about overdoses. We've worked with HIDA and the OD mapping program to track both fatal and non-fatal overdoses by geographic region to try and help us track hotspots or a bad shipment of fentanyl or a bad shipment of heroin to try and spread prevention and awareness. But most importantly, we're trying to work with the community, with groups like this, to spread the word so that people can become educated, so that they understand in this environment, sharing is not caring. You don't know what you are getting access to, and you don't know what you're sharing. And whatever you are sharing can permanently harm somebody. This drug is out there. It is a new and very silent threat. But together, law enforcement and our community partners can spread a message of hope, prevention, and education. Thank you very much.
Stephanie, thank you so much for sharing that information. And as a reminder to the audience, if you have any questions, please just add them into the comments on YouTube, or you can use the submit a question button during the quiz and they'll be answered at the end of the event. Our next guest is Dan Ziegler. Dan is the Spokane Regional Director at Pioneer Human Services, and he is here to help us better understand how, as family members, partners, caregivers of someone struggling with substance use disorder or opioid use disorder, can best navigate and access care. Dan, thank you for joining me.
Thank you for having me.
To kick us off, could you share what signs might be that someone is suffering from a substance or opioid use disorder?
Sure, that's a good question. So I think it's important to know that when a person has a substance use disorder, part of what is that they're having difficulty stopping their use even when they want to, and even when they know it may be causing problems in their life, in their relationships, or their work. It's where you feel normal. And so what comes along with that a lot of times is cravings and withdrawals and this type of a thing. And so sometimes what you'll see is moodiness or mood swings. It can be irritability, which can happen from withdrawal symptoms or when someone is seeking the drug. Sometimes the goes into substance use disorder. But when it goes along with some of these other things, and when the person is taking more time to try to seek out and find the drug and has more irritability around that, those can be some of the signs that someone might have a substance use disorder.
Thank you. And how can I bring up the subject to a person struggling with addiction?
That's a good question, and I think it partly depends on the situation. So I think So the first thing is talk to yourself, to a doctor, or to a substance use disorder professional or counselor who specializes in this. It's going to give you perspective on what the person may be going through. It's also going to be a way that you can educate yourself, and also, because these situations can be difficult, it also gives you support. Give context. The non-judgmental approach. And so part of what that means is that, when someone is struggling, they may be having they're already going to be having a lot of shame or it used to be what we found is that actually isn't very helpful. What you actually want to do is think about it just in any situation in life. When somebody brings something up to you in a really confrontational way, it ends up being a situation where you feel defensive right off the bat, and you feel like you don't want to respond well in that type of confrontational situation. We usually do better when someone says back to us, I don't know if you might be struggling with this. I could understand if you are. I'm here to support you. Is there a way I can help you? Being supportive and compassionate rather than being really. That's not to say that we don't need, for ourselves, there might be boundaries and limitations on behavior that we can tolerate, but having, it doesn't have to be like the show's Intervention where you get 15 people in a room yelling at somebody. That's probably not going to be very helpful. Yeah, so I would say it's better to have a compassionate approach.
Now, if my loved one goes through treatment, how likely is it that they'll be successful in their recovery, and is relapsing common?
Yeah, that's another good question. I think that most people do recover with help and treatment looks for people. Professional that's going to really help guide what that treatment is going to look like, and it is different depending on whether the person has been chronically using their for 15-20 years, or if it hasn't been nearly that long, or if they have chronic health conditions that go along with prolonged use. But I guess relapse is common.
And what kind of treatment options are available?
So there are a lot of good treatment agencies here in our area in the Spokane region, and generally, there are programs disorder treatment. Also, a lot of but really, there's a lot of good treatment options, and a good treatment provider is going to do a really good assessment that's also going to involve a physician, a mental health provider, someone with expertise in substance use. And when a person does get that, opioid use, and whenever help comes and it's really a combination. It's really a good the case with every person, and so that's why it's important to just have a really good assessment.
we're having a little bit of connectivity issues. And so thank you so much for everything that you've shared. I think having the right information and resources is paramount when you're trying to help someone who is struggling. So I'm going to, I know that there's going to be plenty of more questions for Dan, so maybe we can fix some of those issues, and we'll open up back to the audience for questions and answers at the end. Our next presenter is Nicole Perea. And Nicole is the clinical assistant professor at Washington State University, College of Pharmacy and Pharmaceutical Sciences, as well as a practicing pharmacist. She's going to teach us how to use Narcan and where we can get it.
Hello, my name is Nicole Perea, and I am a pharmacist here in Spokane, Washington, and today I'm going to be talking to you about naloxone. So I know we did have our friend Stephanie talk a little bit about what we're seeing with the trends with opioid use disorder in our community and some of that overdose data. But I wanted to introduce the opioid epidemic just as an entire whole concept. So just to put it in a bigger picture, the United States takes up less than 3% of the world's population, and we consume about 80% of the entire supply of opioids and 99% of the world's supply of hydrocodone. So this is a lot of opiates, right? So there's really no question as to why we have an opioid epidemic. But why we're so concerned about it is because we see a staggering amount of deaths every year. So since this became an issue and on our radar in 1999, we have seen 232,000 American lives lost due to opioid overdoses. So this is why we're here today to talk to you about naloxone, which can reverse the effects of opiates and reverse overdose in general. So what are opioids and why are they so addictive? So essentially, opioids are medications or substances that when they enter the body, they bind to those opioid receptors and they set off a whole chain of events. And within this chain of events, they give our bodies lots and lots of dopamine. And this is great when I have a broken arm and my body needs to focus on healing and not the pain that it is causing. It is not so great when I am misusing or abusing these opioid medications and it is causing this flood of dopamine to essentially restructure the way that my brain is thinking. So our body likes to use dopamine as a reward center. It really likes it, so whatever we're doing to make it happen, it wants our body to do more of it. That's why when it really likes all this dopamine from opioids, it's going to want us to do more and more of it. So this is why they are so effective. What are opioids? Well, some common opioids that we see, especially in overdose, are going to be number one, prescription opioids. So as a pharmacist, this is what I am most familiar with, and prescription opioids can be things like methadone, oxycodone, or hydrocodone, to name a few. And for reference, as many as 1 in 4 patients that have prescriptions for long-term opioids do struggle with an addiction. So this is something that is not for people who are prescribed opiates for short-term or long-term or are not prescribed opiates. This is genuinely affecting everybody. So another thing that we have seen is fentanyl. So Stephanie talked to us a lot about fentanyl and how we're seeing it within the community here in Eastern Washington and Spokane specifically. Fentanyl deaths are on the rise, and essentially fentanyl is just a synthetic opiate that is really, really strong. So it is going to attach to the same receptors that our prescription opioids are going to, and it's going to release dopamine, just like our other opiates do as well. But it's going to hold on a whole lot tighter to those receptors. So we see it be a little stronger and last a little longer. Other opioids include heroin. So heroin is going to be an illicit substance that is the same type of molecule just like our prescription opiates. It's going to work in the brain the same way that opioids do, and so it's going to cause that same effect of that release of dopamine. So all of them are going to essentially work the same to make those feel-good effects, but they're also going to work the same way in creating some of our overdose effects too. So we're going to look at this a little bit later on as well. But lots of prescription opioids, and I wondered myself, and I bet you're wondering, how are people getting these opiates? Well, with pain relievers, especially the prescription opioid medications, 53%, so more than half of people who are trying this for the first time are getting it for free from a friend or a relative. After that, we do see people getting it from their doctor as prescribed. exactly how they're supposed to be doing, about 21%. A little bit fewer percentage, so 15% and 4% are buying it either from a friend, relative, or a drug dealer, and then there are some others, whether that's stealing, doctor shopping, or getting it off the internet. So, as someone who rarely goes to the doctor, but I do go to the doctor sometimes, I've definitely kind of run into this before. I'm originally from New Mexico. I come from a really big Hispanic family, and in our culture, sharing is definitely caring. So when I had dental surgery and my dentist decided that ibuprofen would be strong enough to control my pain, he had something at the office just in case I needed it, but he decided our game plan was ibuprofen. I was on board, and my mother was not on board. My mother looked at me and she was like, "Mahita, I don't think that's going to be enough. I have some leftover hydrocodone from my last surgery if you need it." And I looked at her and I said, "Frances, that is a 4th-degree felony." And she kind of laughed it off, and she was like, "No, but really, I don't want you to feel like you're in pain." And I think this is the place where a lot of friends and relatives come from, because they don't want to see their family members in pain. And I think that's a very noble thing to think. But what we have to realize with some of these pain medications is that they can be more addictive than we ever realized, and they can be a little bit more harmful than the good that we're doing in that moment. So keep this in mind as we are moving forward with talking about prescription medications in general. So then that brings us to why we're here. What is naloxone? I kind of teased this in the beginning, but naloxone is essentially a medication that is going to reverse all of the effects of opioid medications. It is working on those same receptors, so we have these opioids who are in our brain, they're hugging tight to those receptors, and they're releasing all of those feel-good chemicals. Unfortunately, when we have too much of it, our body starts experiencing overdose symptoms like not being able to breathe, or having a really low heart rate, or having really small pinpoint pupils and being very drowsy. So when we see these signs in someone, we recognize that this is a job for naloxone. And when naloxone comes into the body and we administer it to our patient, friend, or family member, it is going to kick those opioids off the receptor. So it's going to replace all of those receptors, and it's going to stop any effect from the opioid, which is great. So any breathing that would have been impaired, it's going to reverse it, and we're going to start to see that person breathing again. But any good things like pain management that's been happening with the opioid, it's also getting kicked off, and it's not going to happen anymore. So, is naloxone safe? Yes. This is remarkably safe. It has one of the highest safety profiles as any drugs on the market. But it only works on those opioid receptors. So if there's no opioid, there's not going to be an effect, which is good and bad. So good thing, if it's something else that's wrong with this patient causing them not to breathe, it's not going to make anything worse. But it's only going to work if it's an opioid causing this overdose. So it's not going to work on a methamphetamine overdose. It's not going to work on a benzodiazepine overdose, something like Xanax, Ativan, diazepam. All of those things might look a little bit like an opioid overdose, but unfortunately this medication will only work on opioids. So those hydrocodones, those oxycodones, the fentanyl, and the heroin as well. It's really nice because not only is it safe, but we can give it in a bunch of different ways. We can inject it into our fat tissue, we can inject it into our muscle, we can inject it in the vein, and we can even give it through the nose, whichever is most available to you or the patient. So that is something definitely to keep in mind. So then who would benefit from having naloxone in their house or having it on them at all times? Honestly, patients. So anybody who is prescribed a chronic opiate, somebody who has struggled with opioid use disorder in the past, caretakers. So anybody who is taking care of someone or who is kind of living with somebody else and knows that they might be prescribed these medications, is helping them with these medications, or just is aware that they have a substance use disorder past. Family members. So this medication is really safe. So in case kids get into the medication cabinet, grandparents, something's taken that some way it's not supposed to be taken, family members would definitely benefit from having this on hand and being aware of how to use it. Emergency responders definitely benefit from having naloxone on them. Our Spokane Fire Department and police do have this and have training and are excellent at using it and making this accessible to all patients. And then, of course, healthcare providers. So most notably, your pharmacies locally are going to have this stocked and ready to go whenever you do need it. So then that kind of segues into where can I get it? You can get it from your doctor's office. So if you need your doctor to prescribe you naloxone, they can and should be able to do that. You can also just walk into your pharmacy. Most of your pharmacists in Spokane can write a prescription for you for this and get it sent through and all taken care of right in your one-stop shop visit. So definitely visit your pharmacist for that. And you can get it from the health district. So during the needle exchange programs, our health district is awesome at providing resources like this. So they will have naloxone available in most circumstances. We also do have a standing order in the state of Washington. So what a standing order is essentially it is going to be a prescription that has been signed for every Washingtonian in the state. All you have to do is either grab it at your pharmacy or print it out at home and fill in your information. Once you get to the pharmacy, they can process that standing order and get you that naloxone right then and there. So that is where you can get this medication. So I mentioned we can do this in a variety of different ways, right? So we have a bunch of different types of naloxone. These 4 that you have pictured on your screen are going to be the most common types of naloxone that we do see. And right now I'm going to walk you through how to use each and every one of them. So we have 2 different kinds of injectable naloxone. The first kind is going to be this one. It's called Evzio, and it's really easy to use. This one talks you through it, but it is very, very expensive. So essentially it's going to come in one of these canisters. The trainer is going to be gray like this one, so if you are in an emergency situation, you do need to make sure that you're using the purple one. So it's bright purple to let you know that this has medication in it. For this, it can be used on muscle groups through clothing. So very similar to an EpiPen, if this person has pants on, you can absolutely still inject it over those jeans. So that is something that's really user-friendly about this. And once you take that cap off of it, it's going to start talking to you. So you just pull up and it will start verbally telling you all instructions on how to use this, how long to hold it on, and what you're supposed to be doing. So kind of expensive, but very user-friendly. The next injectable naloxone we have is something that's a little bit more familiar, so this has certainly been around the longest. Our injectable naloxone can come in a vial, and so when you get this from your pharmacy, you do need to make sure that you also have a syringe with you. So an appropriate needle is going to be one kind of like that they use for flu shots. We want to make sure it's going deep enough in that muscle or deep enough in that fat layer to make sure that we are getting the medication exactly where we want it to be. So when we are using this type of naloxone, what we're going to do is you're going to take that bright orange cap right off the top, and you are going to withdraw all of that 1 milliliter out of that vial. So with that 1 milliliter, you're going to put it in your syringe. So I have a demonstration here. It is not a real syringe. This is just for demonstration purposes. And essentially you're going to withdraw the entire contents by pulling this plunger all the way back. And when you are ready to do the injection, you're going to remove all clothing. So not like the Evzio, you want to make sure that all skin is exposed, so we can inject this in a few different places. So if we want to inject it in the muscle, we can inject it in our arm muscle. So our nice deltoid here, on most patients, this deltoid is going to be very visible, this upper portion of the arm, right where you get a flu shot. If you want to do it in the thigh, you can do it on the outer edge of the thigh. That's a nice big muscle group that we do have available too. Or we can do it in the fat layer. So if we are giving an injection within the fat layer, all of us have a nice cushy portion right around our belly button that's going to let us inject right into our belly button, right around it. All of us, unfortunately, have this nice fluffy part in the back of our arms. So if we are able to squeeze any fat together, that's a really nice spot to be able to put naloxone in if we are going to put it in the fat layer. Or right above our buttocks. So right above the buttocks is going to be another really good place to put this naloxone. And when we are ready, we are going to firmly place it on our patient and then push this plunger down. And so most of the time this needle is all the way in the arm, and then you want to push the plunger until it can't go anymore. That lets us know that we have injected all of our medication and that it is ready and in the spot going to work as we need it to. But we can also put naloxone in our nose. So the brand name is going to be Narcan. So Narcan is a little bit newer of a medication. It looks like this little tiny white plunger. So with this medication, again, it's really user-friendly. It can be a little bit more expensive, but most insurance does cover this medication. So you'll see this a little more commonly than we have in the past. For the intranasal naloxone, we have this big portion that's not covered by anything. This is going to be the top of it. That's what goes in our patient's nose. This bottom portion is the plunger. It's really sensitive, so be careful not to push it until it's fully inside of our patient's nose. So we want to grip this device as well as possible, avoiding that plunger here at the bottom. We are going to place it all the way into our patient's nostril until we can't anymore, and then we are going to push this plunger. Once we push this plunger, all of our medication is going to go into the inside of the nose, and it's going to enter the bloodstream exactly where we want it to. So if your patient is not breathing, that's okay. We don't need it to get into the lungs. We just need it to get into that lining of the nose. So for this medication, the entire dose of your Narcan is going to go into one nostril. So deliver the full entire dose, pushing that plunger and getting it into that system as quickly as you can. And that's how you use the brand name Narcan. The other way you might see intranasal naloxone is going to be in the form of this kit. So in this kit, it has 3 pieces. The first piece is going to be the medication itself, so it's going to come in this small little vial. It's a glass vial with a colored top. The second piece is going to be its plastic canister. So this is usually going to be bright yellow or bright orange up at the tip to let you know that this is how you're going to deliver your medication. And then third, you're going to have this little cone. So this little cone is what's going to turn that liquid into a nice mist so that we can get all of that medication into the nose, just like that Narcan we did before. So in using this medication, you're going to do the same thing. You're going to get your patient ready, have their nose available for you to put it in, and essentially you're going to take all these brightly colored caps off. So for our little plastic piece, you're going to take the back off of it. It's a bright yellow cap. And you're also going to take the top off of it. So it's just the clear plastic portion right here. The next thing you want to do is you want to take your brightly colored cap off of your glass vial. So this contains our medication, but don't worry, it won't fall out when you take this lid off. It's nice and safe inside of there. And so we want to take that stopper off so we can put it into our plastic device. So in our plastic device, we have this nice kind of flat part that has room for our fingers. This is where we are going to insert in our naloxone. So in the portion that you took off the cap, there's a nice hole there. You just want to push that all the way in here and screw it in until you can't screw it anymore. Once it's pretty secure in there, you'll feel it and it won't keep going and you're ready to go. Now we're going to put on our little cone. So our little cone is called an atomizer, and this just screws onto the other tip of it. So at the very top of it, this is what our assembled product is going to look like. So this allows us to turn this liquid into a mist so it goes into my nose. So when we're ready to give this to our patient, there's a lot more liquid in here than there was in our Narcan. So we're going to put half of it in one nostril and half of it in the other. So we're going to get this nice and cozy all the way up into our nostril, and this one is going to be a little harder to push. So if you don't push hard enough, it's going to come out in a little stream. So I'm going to try and show you here. So that was kind of misty, kind of streamy, but what we want it to look like is a full stream. So give it a good, nice push, and that's going to make sure that all of this is going to get nice and misty so it goes into our nose. So the nice mist is going to look like this. You see that? Nice and misty, and it's not going to just dribble out the nose. It's going to stay exactly where we want it. So we're going to do half in one nostril. Nothing is going to tell you when that half is up. You just kind of have to estimate. You don't have to be precise. You don't have to be exact. Just do the best you can. If you're paying attention to it, more often than not, you're going to hit it right on the spot. So half in one nostril, take it out, and do half in the other nostril. And then you've completed this naloxone dose. So that's essentially how to use naloxone. So now we're going to look at the 5 steps in an overdose situation and how to kind of put it all together. So here are 5 steps: calling 911, checking for an overdose, supporting the breathing, administering naloxone, and then monitoring that response. So when we call 911, we want to do this first and foremost. Whether you have checked for an overdose or not, if you suspect an overdose, it's time to call 911. You want to explicitly verbalize that someone is not breathing, that they're not responsive, and that you are concerned about it. Giving a very clear address or description of where you're at gives them the most efficient response to getting to you. And this step is crucial. So whether or not your patient responds to naloxone, or you think it's an overdose, or you are certain it is, you call 911 first time, every time. Next thing we're going to do is we're going to check for those signs of overdose. We kind of mentioned this. Our biggest thing is our patient's not going to respond to us. So if I'm calling out their name and they're not responding to me, I'm shaking them, I'm rubbing their sternum, and they're not responding to me, they're likely not as conscious to be able to respond, breathe, etc. So we want to make sure that we are trying to get their attention, and if we're not able to, checking these other signs. Another really hallmark sign of opioid overdose is going to be that really slowed or stopped breathing. So you usually will not see the chest rise and fall with those breaths, but sometimes you can even see the tips of the fingertips turn blue because that oxygen isn't getting to those really tiny spaces like our fingertips, or you can check the inside of the lip. So on the inside of the lip, if that's turning blue, that's another sign saying, oh, their body's not getting enough oxygen, I should be concerned. Another thing is you can see the face get kind of clammy, it might look really pale, they're limp and again not responsive. It could be possible that if you're able to see their pupils, that their pupils become very, very small. So those pinpoint pupils, you don't see that dark portion in the middle of the eye, it's just like a little pin dropped right in the middle. Or you can maybe feel the heartbeat go really, really slow instead of the normal dun-dun. And in some severe cases, this patient can also be vomiting or audibly struggling to swallow. So anything that's really inhibiting their natural ability to breathe or swallow, that's also very concerning. So they can have some of these symptoms or they can have all of them. It's really hit or miss on our patient. So it's very dependent on what we're looking at. Just make sure that possibly they have some of these. So the next thing we want to do is support the person's breathing. So before giving the naloxone, we want to make sure whatever way we're giving it, we have that site ready to us. So if you're injecting in the arm, make sure you can reach the arm and you can feel it and it's free of clothes. If you're injecting or doing the intranasal into the nose, make sure their nose is free and clear and that you have a good access point to get that device into their nostril. Once they are ready and set for that Narcan delivery, you can put them in the recovery position if it allows, the way that you are administering this medication. And what that looks like is them essentially laying on their stomach with their bent knee, stopping the body from rolling completely onto the stomach, and their hand supporting their head. The reason we do this is just in case they do start vomiting, it will not come back into their mouth and they do not accidentally swallow and or choke on it. If you are comfortable and able to do CPR, this is where you might be able to start that. If you are not comfortable doing CPR or you don't know how to do CPR, don't do it. It's okay. It's not super crucial as long as we are identifying that we've called 911 and we can give them naloxone. So the next step after getting them ready would be to administer the naloxone, and we know how to do this now. So no matter what type of naloxone you had, you are familiar with how to use it and how to explain it to others. Just to note, this naloxone is only going to last in the body from anywhere between 30 and 90 minutes. This is great and it works well within those 30 to 90 minutes, but some opioids can last between 4 and 72 hours in the body. So that's a lot longer than our naloxone is going to last. If we see our naloxone working, it can go away after that 90-minute period, and if we still have opioids in our body, they're going to start working again. So unfortunately, we can see those overdose symptoms after our naloxone is done working. So this is why we always call 911 too. You might need multiple doses. So in every form of naloxone, you're going to get 2 doses in every prescription. So why we give 2 doses is if we don't see enough response after 2 to 3 minutes, give another dose. It's okay, it's safe, and it might be beneficial for your patient. So, reasons why we might need to give another dose. Sometimes we're taking a lot stronger opioids than naloxone is as strong. So one example is going to be those synthetic fentanyl types of medications that Stephanie was talking about. Those medications are made by man, and they're really, really good at what they do, unfortunately. So they hold onto those receptors very, very tightly. And when they hold on more tightly than naloxone, the naloxone may not have as much of an effect. So that's why, again, we want to call 911 every single time. So my question for you is, can a patient die from withdrawal symptoms if we give them naloxone? The answer to that is no. Different from alcohol overdose, for opioid overdose, our patients cannot die from opioid withdrawal. They can die from alcohol withdrawal, but not from opioid withdrawal. I know some family members and caregivers kind of get concerned about this, which you should be, but just know that as you're giving naloxone, it is safe to give and they will not die from those withdrawal symptoms. And our last step is going to be monitoring that response. So like I said, we want to see some of that breathing come back in about 2 to 3 minutes. If we don't see it after that 3-minute mark, give another dose of naloxone. We want to continue rescue breathing if we're able to during this time to get as much oxygen into that body as we can. However, if a patient is not responding to naloxone, it could be that something else is going on, something else that isn't allowing them to breathe, which is, again, why we're glad that we called 911 in the first place, as opposed to after giving the naloxone. So a patient may need more supportive care after this. If they do have one of those opioids that is lasting a really long time in the body, sometimes they need to be monitored in the hospital to make sure that they don't see those overdose symptoms again. So that's why we want to make sure that not only we call 911, but that we are also following up with that 911 call and sending them to get the appropriate care that they need. So that is it for our naloxone portion of this. If you do have any questions, I will be at the live panel question and answer, and I would be happy to answer any questions that you might have about naloxone or these prescription opioid medications. I very much so appreciate your time, and I hope you have a wonderful day. All right, we did it.
Thank you for that excellent demonstration, Nicole. At this time, I'm going to invite our guest presenters back, and we'll go ahead and open up the questions and answers to the audience. So if you have any questions, please submit those via the comments on YouTube, or you can submit them using the quiz app, and we'll try to answer as many questions as possible during our event. All right, so it looks like the first question that we have is directed to Stephanie, and why is fentanyl being distributed in such powerful doses?
Well, I think that's a great question. The problem is that the fentanyl that we are seeing illicitly on the streets, there's no quality control. There's no measurements. There's no consistency. Powder fentanyl is just being dumped into pill presses and being sold on the street illegally. So the user does not have any idea what kind of quantity is in each pill that they may be taking, and there's no consistency amongst the batches.
And this next one is for Nicole. Why is Narcan issued in 2 doses?
Yeah, that's a good question. So the reason why Narcan is issued in 2 doses is to make sure that you have enough on hand and in stock to be able to administer in case you need a second dose. You want to see that patient's breathing at least come back a little bit more consistently when you give the first dose, and if that's not happening, it's always best to just give that second dose.
Okay, and how would a person typically react when given the Narcan?
So how a person would react when given Narcan does depend person to person. Since this is reversing every effect of the opioid, so all the bad ones, but all the good ones, patients can be a little frustrated, and that can escalate to being combative. This is less likely if they understand what setting they're in and they know who's around them. The more foreign the setting and the more foreign the person giving them this medication can result in a little bit more combativeness when administering it.
And what is my cost for Narcan?
So the cost for Narcan is going to be a little bit different for everyone. It depends on if you run it through insurance or not. If you do run it through insurance, it will depend on your copay. If you do not run it through insurance and you purchase name brand Narcan, that retails at about $140 for 2 of them.
Thank you. And Dan, this one's for you. What can I do to help a person that is not ready to seek help?
You know, if you have someone in your family and someone that you're living, in close, in the same home as or in close proximity, I think that's when it is important to connect yourself with a counselor who specializes in this and help kind of walk through. There might be, there might be things on your end around boundaries and, behaviors you can and can't tolerate that you need to be able to know for yourself kind of where your limits are and what's healthy and what's not healthy. And so that's going to be important that you're not doing that in an isolated context with just you in that in your home. It's good to have a counselor or some professional help to help you walk through that. And there can also be great support groups. There are things like Al-Anon, and many churches have, and faith groups, different faith groups have different support. So it's good to get yourself some support, because sometimes when someone is in active addiction in the home, it can take on a life of its own. And so you want to be able to have outside perspective and support for yourself and insight.
Thank you. And Nicole, what happens if a person is given Narcan that is not overdosing?
So the good thing about Narcan is it only works on those opioid receptors. So if they are overdosing from another substance or they are experiencing another health emergency, typically we do not see any negative side effects from this naloxone. It simply binds to the receptors and does nothing. So that is really why it's so safe to be able to use in so many patients.
Great, thank you. And Dan, on average, how many times does a person relapse?
There's not really an average in that sense. It depends on a lot of factors, like how chronic the use has been, how many years has the person had a substance use addiction. And so, the less time that someone has been chronically addicted, the probably less relapses they may have if they're getting help and treatment, and if they're engaged with a doctor. If a person has been using a really long time, most likely there's going to be more relapses than otherwise. And then in some cases you do have folks who don't relapse, and that does happen from time to time, but it's not the norm.
And Nicole, I think this one might be best suited for you, but how do I dispose of opioids properly when taken from users?
Yeah, that's a great question. So the most environmentally friendly way to dispose of medications is going to be to utilize any drug take-back opportunities. Our U.S. Attorney's Office actually hosts a couple of these every year in coordination with the DEA. So twice a year, they will take back all of your meds and they will dispose of them properly. But sometimes we need to dispose of them a little bit more quickly. So a lot of substations and pharmacies around Spokane also will take back medications. I would recommend calling them beforehand so that they can guarantee whether they do this service or not, which tends to be the best. Otherwise, you can put them in a baggie with some cat litter or dirt, put the pills inside with it and a little bit of vinegar and water, shake it up, and dispose of it in the garbage. So that is one of the better ways to break it down, but also not dilute or pollute our water systems.
It's very interesting. And Stephanie, a question for you. Why are we seeing an increase in fentanyl now?
I'm not sure I have a complete answer, but what we do know is since we started to see it introduced in 2016, it has been a focus of several of our criminal organizations. It's much cheaper for them to make. They don't necessarily care about the end consequences. It's easy for those organizations to smuggle them across the border because they can hide them in what looks like a regular pill instead of other illicit narcotics. So it's cheaper for them to make, it's easier for them to smuggle, and they can do so in large quantities. And now they've unfortunately created a demand where people are actually looking for fentanyl-laced pills, what is so scary. So they've changed the ingredients, they've added different types of analogs of fentanyl to include the very, very deadly carfentanil. So we're seeing an increase because it's a focus of the organizations, they make more money on it, and it's cheaper for them.
And do all first responders in Spokane carry Narcan?
So for Spokane, our fire department all carries Narcan, and our EMS carry Narcan as well. Most of our police units do, and I believe our sheriff responders do as well. So we do have pretty good coverage in Spokane.
if I call 911 for someone else but have drugs on me, will I be arrested when the police arrive?
Is that a question for me?
Whoever's most equipped to answer that one.
I obviously there's no crystal ball in facts and circumstances, but if you're calling 911 for the help of somebody else, we're going to focus on helping the person that is in need of help. If you put yourself in a situation where you're potentially interjecting into this scenario and the police have to make contact with you, that might create a different result. But mostly if you're calling 911 for help, then they're going to respond to help the person that you're calling who needs it.
I will just add to that, Stephanie, that in Spokane and in Washington, we do have a Good Samaritan law as well. So if you are calling with good intent to help someone, like Stephanie is saying, then you will not be charged with low-level crimes such as having drug paraphernalia around you. That is not the intent of the visit, and they would much rather save a life than they would charge you with a low-level drug crime.
Great, thank you for that. So it doesn't look like we have any more questions this evening. I do want to thank Stephanie, Dan, and Nicole for joining me this evening and sharing such valuable information, and a huge thank you to everyone who's joined via live stream. We hope that this has been informative and helpful, and I encourage all of you to stick around and answer the last question on the quiz before signing off. If you have more questions, we invite you to visit drugpreventionspokane.org. There's a wealth of information and links to additional resources. And any other questions that get submitted that have not been answered this evening, we'll go ahead and post those under the events page. Thank you and have a wonderful evening.